Hi everyone, my name's Dr. Naranie Shanmuganthan and I'm a haematologist in South Australia working at the Royal Adelaide Hospital, SA Pathology and SAHMRI. I've also been fortunate enough to do my PhD with Professor Tim Hughes and Professor Susan Branford as well. So I have been asked to give a presentation today. And so I won't actually need to go over the concept of treatment-free remission, as this will have been covered in a separate talk. Instead, I'll focus on describing the best candidates for a TFR attempt and the evolution over time over the selection of patients for a TFR attempt. So the first TFR studies had relatively conservative selection criteria for patients for a TFR attempt. The eligibility criteria for the Australian Twister study, which was published in 2013, enrolled 40 adult CML patients that had been treated with imatinib, although prior treatment with interferon was permitted. Patients also had a minimum duration of undetectable BCR-ABL for 24 months and 36 months of imatinib therapy. Sustained undetectable molecular remission was defined as no detectable BCR-ABL with an assay sensitivity to a minimum of MR5. However, despite the minimalistic entry criteria, the median duration of imatinib therapy was 70 months prior to the TFR attempt, although this failed to predict TFR outcomes on further analysis. But there was also a suggestion that interferon therapy prior to imatinib treatment may have also been a predictor for TFR success. Similarly, the French STIM study, which was published a little earlier, demonstrating the feasibility of TFR in a population of 100 imatinib-treated patients. These patients had a minimum of 2 years of complete molecular remission to a sensitivity of MR5. And despite the minimum criteria being that of at least 3 years of imatinib treatment required prior to the TFR attempt, the patients had a median of 50 months of imatinib treatment. Furthermore, having longer duration of imatinib therapy in this trial, that is, having greater than 50 months of imatinib treatment, did predict for TFR success. Interestingly, the clinical risk score did appear to correlate with TFR outcomes from this study. Since the earliest two studies, though, there have been numerous other clinical trials that have investigated the potential of TFR in imatinib-treated patients, each having their own eligibility criteria. In this time as well, the threshold for molecular relapse also shifted, with TKI recommencement being originally initiated for loss of undetectable MRD, whereas later studies have accepted loss of major molecular response as the preferred target. The rates of successful TFR from the imatinib studies range from about 40 to 60%, depending on the study and the time point assessed. So if we shift focus to the Euroski study, which was the largest TFR study to date, with the interim analysis being published a few years ago. Data of 755 patients were evaluated, with the eligibility criteria for the study being a lot less stringent compared with the earlier TFR studies, but patients still having to have a minimum of 3 years of any TKI therapy, but the molecular criteria was a minimum of a year of deep molecular response, which in this study was defined as MR4, or a BCR-ABL of 0.01%. Despite the looser eligibility criteria, the median TKI duration was still 7.5 years, with a median duration of deep molecular response being 4.7 years. Investigation into the potential variables that could be associated with TFR, defined in this study as remaining in major molecular remission 6 months post-drug cessation, it was found that the duration of TKI prior to the TFR attempt was a very strong predictor of TFR. Likewise, the duration of DMR prior to the TFR attempt was also relevant. Statistical modeling focusing specifically on imatinib-treated patients also demonstrated that the probability of TFR was substantially higher if the duration of TKI therapy was greater than 5.8 years and the DMR duration was greater than 3.1 years. Additionally, unlike other earlier data, namely the STIM study, the SoCal risk score was not predictive of TFR outcomes. So given the rates of success seen in the imatinib treatment with TFR, the next question was whether more potent TKIs, namely the second generation TKIs, would be far more successful with TFR. So this is a table representing all of the second generation TKI studies that were published as of last year. And as can be seen, the rates of TFR success has not really been demonstrated to be substantially superior to imatinib treatment. But perhaps the area where second generation TKIs could impact upon TFR is the duration of therapy prior to the TFR attempt. The first-line DADDY study having only 40 months of dasatinib therapy prior to the TFR attempt, with a 55% rate of TFR at 12 months. And the Enos Freedom having 44 months of first-line nilotinib therapy prior to the TFR attempt, with a 49% success rate at 96 weeks. So perhaps attempting TFR with a second generation TKI in the first-line setting will enable patients to reach their milestones as well as TFR eligibility criteria far sooner. So the complicating thing about the variables that predict for TFR is that different variables have been shown to be predictive in some studies, but not others. The age of patients at the time of the TFR attempt has been investigated as a potential predictor of TFR outcomes. The ISAB study, which enrolled 112 patients with 48% of patients relapsing and requiring imatinib recommencement by 12 months. While the study was not able to demonstrate an association with imatinib or DMR duration as well and TFR success, it did demonstrate a correlation with age. Patients were categorized based upon age, and almost all patients below the age of 45 had a molecular relapse. In comparison, only 42% of patients aged between 45 and 65 and 32% of patients aged greater than 65 relapsed. This study also demonstrated that patients who tested positive on digital PCR had a higher probability of molecular relapse. Combining age and digital PCR in a Kaplan-Meier graph demonstrated that patients who were greater than 45 and were digital PCR negative had the highest probability of remaining in TFR. The SAHMRI study enrolled 84 patients treated with dasatinib, and 46% of patients remained in TFR at 24 months. The variables that emerged in this study as predictive of TFR at 2 years was longer duration of prior dasatinib therapy and age greater than 65. But there are also other potential variables that have been used to predict for TFR success. The BCR-ABL transcript has correlated with TFR success, with a number of groups now demonstrating a higher chance of molecular relapse in patients harboring the E13A2 transcript in comparison with the E14A2 transcript. Claudiani and the Hammersmith group demonstrated that 64% of patients with an E13A2 transcripts will experience molecular relapse, compared with 35% of patients with an E14A2 transcript. These findings were also confirmed by the Italian group, where only 20% of E13A2 patients remained in TFR, represented by the black line, and 60% of E14A2 patients remained in TFR, and that's represented by the red line. Australian TFR data also demonstrated that the early molecular response following TKI initiation at the time of diagnosis of CML was also associated with TFR success. In this study, halving time was used as a surrogate marker for the rate of BCR-ABL decline, and from 102 patients who attempted TFR, patients with a sustained TFR at 12 months had a shorter median halving time of 10.1 days, compared with patients with molecular relapse, which was 21.7 days. Logistic regression also confirmed that the likelihood of sustained TFR at 12 months was lower in patients with longer halving times. For example, patients with a halving time of about 10 days who attempted TFR, once eligible, had almost 75% probability of sustained TFR at 12 months, falling to approximately 12% for patients with a halving time of 40 days. The question of how much the immune system has to do with TFR is also another topical area of research. From the first two TFR studies, the TWISTER and the STIM study, there did appear to be a signal that patients pre-treated with interferon had higher rates of TFR. In both studies, patients composed about 50% of enrolled patients, and this is reflective of the treatment landscape of the early 2000s, especially if patients had been diagnosed with CML in the pre-TKI era. When we look at the TWISTER data, the median time to undetectable MRD was 244 days in patients who had been treated with interferon upfront, compared with 475 days in patients who had been treated with imatinib upfront. And a higher proportion of the interferon-treated patients were in TFR at 3 years. Similarly, in the EUROSKI study, pre-treatment with interferon was also identified as a predictor of TFR. What was also identified was that the patients with longer duration of interferon pre-treatment, defined as greater than 1.5 years, were far more likely to remain in TFR at 6 months at 86%, compared with 56% if interferon pre-treatment was less than 1.5 years. However, this observation may well be secondary to selection bias of patients. Regardless, in this current TKI era, interferon therapy has minimal relevance as it is infrequently used, although there has been a recent resurgence given the utility and combination of pegylated interferon with standard TKI therapy. Several studies have also reported that the numbers of immune effector or suppressor cells in peripheral blood are associated with TFR outcome. In the DADDY study, higher levels of NK cells and lower levels of gamma delta T cells and CD4 positive regulatory T cells were associated with TFR. In DSTOP, lower levels of CD3 negative, CD56 positive NK cells, CD16 positive, CD56 positive NK cells, and CD56 positive and CD57 positive NK large granular lymphocytes were also associated with TFR success. Subgroup analysis of 100 imatinib treated patients from the EUROSKI indicated that a higher NK cell percentages at the time of TKI cessation were associated with a higher probability of remaining in TFR. The EUROSKI biomarker study investigating gene expression in TFR identified that genes involved in immune exhaustion and immune surveillance were differentially expressed between patients with TFR and relapse, with a specific inflammatory gene signature in the relapse cohort. And finally, Australian data demonstrated that the natural killer cells with increased expression of activating NK receptors were higher in patients who achieved TFR. From this data, an immune score was also developed which generated effective prediction of TFR success calculated from absolute NK cell values, T regulatory cells, and monocytic myeloid-derived suppressor cell counts. So when we're evaluating for the ideal TFR candidate, there are a number of factors that we need to consider prior to the TFR attempt. Firstly, logistics. Patients will need to be highly compliant with the molecular monitoring regime set out by their treating clinician, which can be up to monthly testing in the first 12 months. Patients need to be able to be monitored with a highly sensitive test with a minimum BCR-ABL sensitivity of MR4.5 available with a reasonable turnaround time. And furthermore, the clinician needs to be able to rapidly action a significant result. So the result needs to be made available, but also notified to the treating clinician. But when looking at patient factors, patients need to have a quantifiable transcript, that is, a major transcript type that can be quantified, such as the E13A2 transcript, the E14A2 transcript, or both transcripts. The atypical transcripts are much more difficult to quantify and may only be quantifiable in a research setting. Ideally, avoid high-risk patients, that is, patients that have had a history of blast crisis. And in terms of the ideal duration of TKI exposure and deep molecular remission, longer durations appear to have better outcomes, as evidenced by the EUROSKI data, with both TKI duration of 5.8 years and DMR duration of 3.1 years having a benefit in TFR outcomes. And the other thing that we recommend is for patients that are newly diagnosed, they should be considered for early consideration of TFR, as this may influence the initial TKI selection at initiation to minimize TKI exposure long term. That is, patients that have a high priority of TFR may be better off starting off with a second generation TKI to minimize their TKI exposure in the long term, but also maximize their maximize the opportunity to reach TFR eligibility in a timely fashion. And I might end my presentation there. Thank you.